Hello everyone, welcome to this video of the TOG article, Tuberculosis in Pregnancy. It is from one of the very recent TOG article from the July 2023 and really a new topic, of course, seems to be very important for the exam. So let's make it very much palatable for you all, from our part 2 and part 3 candidates who can use this information for their exam. And of course, anybody who would like to upgrade in OBGYN, this is a good opportunity to update your knowledge. So let's take it as tuberculosis in pregnancy. Take a journey through 3 decades of the global health challenges. Tuberculosis has affected almost 9.9 million lives and it claims almost 1.3 million above those. So it's a big killer. And the battle usually starts from the highest thing started from the West Asia and the Africa. And surprisingly, the 8 main countries, including the giants like India and China, they bear most of the burden. But in UK, why we are talking in UK? In UK, previously the incidence was low, but now it has increased. Why it has increased? Because of the people migrating to that area. So the chances of them showing up the signs and symptoms is more in the initial 5 years of their migration. As the people are too much migrated because of their profession, so TB resurgence is of course coming up again. The other factors like poverty, the HIV reinfection, or the drug resistance. These are the other factors which are contributed to the resurgence of the tuberculosis. WHO has put up a goal to eradicate the tuberculosis by 2030. Let's see how much we are working towards that. So the main factor for now, which we are concentrating on, is early detection and treating the patients appropriately. For that, we need our eyes open to recognize the patients for which we need to do the screening, take up a proper screening protocols, and then go ahead with the management, right? So let me take you through this complete journey. So as we move forward, first we'll start with the pathogenesis or the pathophysiology. The bacterium related to the condition, causative organism, Mycobacterium tuberculosis, we all are very much aware of. It's a non-spore forming aerobic and non-motile bacillus which spreads through the airborne transmission. It also can spread through the unpasteurized milk or maybe small invisible aberrations in the skin or the conjunctiva. And finally, when it enters into the respiratory system, it moves into the alveoli where the war between the macrophages and the bacteria starts. And as the war is there, most of the bacilli are killed or the infection is just confined to that particular area where the macrophages get transformed into the granulomas. So a granuloma is formed. But sometimes in some patients, particularly the immunocompromised patients or patients who have HIV, this can also spread ahead and can lead to disseminated or the miliary type of tuberculosis. So we can have 3 types of pictures. Patient may have a latent tuberculosis, that is the bacilli are there. Or if you do a screening test, you find that presence of bacilli infection is there, but patient is not showing any signs and symptoms. Then there is an active tuberculosis where the patient had an infection and signs and symptoms are there. Then there is a secondary tuberculosis where later on the condition, there is reactivation and patient again has a secondary type of symptoms. So latent, active, and secondary, they are the 3 possible outcomes. Now, 20% of the active TB cases, they may have extrapulmonary symptoms as well. So there is extrapulmonary tuberculosis, but tuberculosis is not just confined to lungs. It can be anywhere in the body. So pulmonary and extrapulmonary tuberculosis. So in UK, what is the picture? Cervical lymph. Cervical lymph nodes are the one which is the most common presentation for the extrapulmonary tuberculosis, and almost 31% of the cases of extrapulmonary tuberculosis are cervical lymph nodes. Other areas are central nervous system, spinal cord, abdomen, pericardium. So as we go ahead, now we know what are the types, what are the outcomes we can see in a patient. Now the next thing comes at what are the clinical signs and symptoms? How will we recognize or how we'll see that this patient can have a tuberculosis? So of course we all know cough, chest pain, hemoptysis. Very commonly we see in the pulmonary tuberculosis, and particularly if the cough is lasted for more than 8 weeks. But WHO has given a four symptom screening protocol. So this 4 symptom screening protocol actually gives you the advantage that if it is there, at least you have to screen patient for the tuberculosis. But definitely this does not mean that if those 4 symptoms are not there, you are not going to do the screening. If you suspect that the patient can have tuberculosis, go ahead with the screening. But the 4 symptoms which the WHO has proposed for the screening is basically the fever, night sweats, and cough and weight loss. Fever, night sweats, cough, and weight loss. So if these are there, certainly we need to do the test. So according to this, there is a protocol which is being done, what tests to be done in the latent and what are to be done in the active ones. In the latent one, you have to do only the screening test. You screen. If it is positive, you have to treat according to the latent tuberculosis, and that too if required. We'll talk about the treatment of latent tuberculosis in the same video as we move forward. If it is an active tuberculosis, then we have to do screening, we have to confirm, and we have to do the drug sensitivity and treat the patient accordingly. So what are the tests available to us? 3 categories of tests are there. There are 3 categories. One are screening tests, then you use confirmatory tests, and there are certain additional tests. So what are screening tests? Screening tests, basically you screen. So you have tuberculosis skin test and you have IGRA, that is interferon gamma release assay. So 2 types of tests, skin test, skin tuberculin skin test, and the IGRA. There are 2 types of screening tests. Confirmatory tests are, you can view the organism directly under the microscope after staining. So they are microscopy and culture and sensitivity. Then there are certain additional tests which are like imaging studies where you have to see where actually the bacteria is causing the damage and how much damage is being caused. So various imaging studies are included in additional tests. For the skin test, we have been reading for a long time MRCOG test, which use a PPD, which is injected in the skin, and you see the delayed hypersensitivity reaction in the form of erythema, which appears in 48 to 72 hours. It's safe during pregnancy, but it has a high chances of false results because of its correlation with the other non-tubercular mycobacteria as well. The CTB skin test was introduced. CTB skin test. First, we talk about the MRCOG, which was using PPD. Now it is CTB skin test. This uses the ESAT6 and CFP10 antigens, and it has shown lower false positive rates. The other test which is largely used in the screening program in UK is the IGRA. So interferon gamma release assay. So what happens is, as the name indicates, you actually spot, it acts as a detective and spots the cytokine interferon gamma, which is triggered by, which release is triggered by the tuberculous specific antigens. So this is more in tune with the tuberculosis, as it is not, it is basically not fooled by the BCG vaccination. So as the persons who have been previously vaccinated by the BCG in their countries, when they are tested in UK, they may show false positive MRCOG test because of their BCG vaccination. But IGRA will not come. So IGRA, that is the cool thing about the IGRA. And it can be used in pregnancy as well. The only concern is that we cannot differentiate between the latent or the active infection. Then comes the confirmation, microscopy and culture. They are the basic tests which can be used for confirmation. For microscopy, we use the Zeal-Nelson stain and the fluorescent rhodamine dyes, which can be seen, which can stain and we can see the bacilli. But the problem is we miss almost 1/3 of the cases, active tubercular cases, with these stains. So WHO has given alternative tests. They have recommended alternative tests like loop-mediated isothermal amplification, gene expert, which is used specifically for the HIV positive patients. These tests can be used. Now, what are the medium where we can grow? Lowenstein-Jensen medium. We have been reading this since our MBBS days. But it takes weeks for the results, 4 to 6 weeks to find the appropriate bacterial culture, and 8 to 12 weeks if we go ahead with the sensitivity testing. So long period. So we can use liquid cultures like BD-TM or MGI-TTM, which can be used and for the early detections. In imaging, as the pulmonary tuberculosis is the one main responsible, so chest X-ray, that acts as a very valuable screening tool during pregnancy. You can see the lesions there. The one important lesion, Ghon's focus. Ghon's focus. So what is this? This is basically the primary lung lesion, which causes the changes in the lung like cavitations, and along with that, the lymph nodes, the hilar lymph nodes are involved. So this complete complex is known as the Ghon's complex. And the focus in the lung is known as the Ghon's focus. So basically, chest X-rays are the screening tools which can be used. Chest X-ray, is it safe in pregnancy? Of course, yes. Very low radiation risk, and with the proper shielding of the fetus, you can use the chest X-ray for your patients. So you can see patchy shadows, cavitations, or old healed lesions in the lungs. Additionally, you may require to do the ultrasound, MRI, or the CT. If particularly you are looking for the abdominal tuberculosis, ultrasound. And if you are looking for the head, spine, MRI, and the CT can be used. Of course, CT is not a preferred thing because of the risk of radiation. But if required, then you have to keep the risk in mind and decide to do the test. What is the risk? With one risk of the pelvic irradiation, the risk of childhood cancer is almost doubled. That is, usually the risk of death due to childhood cancer is 1 in 1,000. But with the exposure of the CT to the pelvis, this becomes doubled and become 2 in 2,000. So we have to be very careful while we choose. It is almost 5 to 7 rads of radiation in CT pelvis. Right, so till now we have talked about the epidemiology, we have talked about the pathogenesis, and we have talked about the clinical signs and symptoms used for screening, and we have talked about the screening tests. Before I move on to the management, which would be the last part, before that, a word about the extrapulmonary tuberculosis, because we might miss signs and symptoms of these conditions. So a just quick review of what signs and symptoms you can see. So signs and symptoms will depend on what organ is being affected. And every time when we talk about the screening, we will talk about the culture and the bacterial staining. So we need some amount of tissue or some amount of fluid. So according to the part involved, we'll be taking the appropriate tissue or the fluid, right? So if we talk about the abdomen, then pain, nausea, vomiting, altered bowel habits can be there. And you can feel any lump, abdominal mass. It could be liver involvement leading to jaundice, hepatomegaly, ascites. And of course, you will be looking at you will be finding or searching for some aspirate or the tissue through the ultrasound, CT, or the MRI guided biopsies. Then, as we come to the CNS, we can have two types of presentation: meningeal presentation or some abscess formation in the brain. So for meningitis, you may have neck stiffness, kerning signs positive, or visual disturbances can be there. Seizures can be there. So there can be muscle rigidity as well. If the lesion is in the brain, that will act like a space occupying lesion and can affect any part of the brain, causing some type of functional disturbances, visual disturbances, depending on what area is being conquered by it. It will also lead to papilledema, pressure effect, cranial nerve injury. Again, we need the same fluid or some tissue. So CT head, MRI can be used to take out the tissue, or you can use the CSF aspirate to look for the AFP. Skin lesions can be there. Lupus vulgaris or non-healing ulcers can be there. Biopsy aspiration is again required. Genitourinary tuberculosis. If the urinary part is involved, hematuria, there can be renal abscess. Or in the cases of genital organs, then you can have vaginal discharge, irregularities of the periods, amenorrhea, or you can have TO mass. So these all things a patient can just present with the infertility as well. Again, you have to do the ultrasound, CT, MRI. You can use the menstrual blood. You can use the urine to look for the AFP. Now, how does tuberculosis affect pregnancy and how does pregnancy affect tuberculosis? Pregnancy is a state of immunosuppression. So, what happens if the person is immunocompromised, more likely to get the disease if exposed, or if the bacilli are already present in the body, more likely to get reactivated. So, more chances of reactivation and more chances of getting a primary disease. So, that is how pregnancy affects the tuberculosis. Now, how does tuberculosis affects the pregnancy? Maternal part and the fetal part. So how does maternal part is affected? Mothers can have miscarriage, can have a high risk of developing anemia, 41%, and she can also go into the preterm labor. And another important thing is that there can be small for gestational age or oligoamnios. So these are the risks that pregnancy can cause to the mother. Also, some studies have shown that there is increased incidence of development of GDN as well in these patients. In babies, we have a perinatal infection which can occur. So in perinatal infection in babies, basically either they can get a perinatal, that is through the placenta, or the amniotic fluid, or from the blood, they can get the infection in situ. And they can show the ultrasound features cannot be very well differentiated as compared to other infections. There can be many common features, but as the baby is born, if the lesions appear very quickly within first week and you don't find any external contact there, then most likely the baby is carrying it from the perinatal period. And in these babies, the most likely lesion is in the liver, and they may present with the miliary tuberculosis as well as, and mortality and morbidity is very high, up to 30% in these babies who acquire the perinatal infection. Babies may also acquire the infection in the neonatal period after they are born, particularly if they are in contact with a person who has active tuberculosis. If the mother has recently been diagnosed and not undergone seroconversion, then she can be the herself or active one to transmit the disease to newborn. So as I mentioned, liver granulomas is the feature which you most commonly see. For treatment, it is almost the same as adults. Same drug regimes are used, but of course, doses are as per the neonates. One important topic which needs a small mention here is co-infection with HIV. That actually increases the probability of getting a multi-drug resistant tuberculosis or increases the chances of getting relapse. So HIV itself is a risk factor which increases almost 20-fold chance of TB reactivation in the pregnant population. So it's a very, very important thing, and it also increases the complications in the mother, like anemia, eclampsia, placenta acarita, drug abuse, and mental health disorders like depression during pregnancy. Okay, so we have talked about the neonatal conditions. We have talked about the clinical signs and symptoms of all the things. Now we have to talk about the management, how to manage. Of course, it's a MDT affair, multidisciplinary team affair, where the obstetrician, infectious disease people, the microbiologists, they all require to be present in this thing. And the same 6 months course that is used with 2 months of 4 drug therapy and 2 months of, 4 months of 2 drug therapy. So initial 2 months, 4 drug therapy, followed by 4 months where you have to use only 2 drugs. And together it makes a 6 months. If it is a central nervous system, then we have to extend this remaining 4 months of the 2 drug therapy to as long as 12 months. All drugs are safe in pregnancy. No issues. You can continue using them. Only the streptomycin is not recommended because it has 15% chance of developing a neonatal deafness, which is irreversible. So streptomycin is not used. 4 drugs which are used include the isoniazid, rifampicin, pyrazinamide, and ethambutol. So let's look at these drugs one by one. Isoniazid is the drug. The 2 main issues are hepatotoxicity and the peripheral neuritis. So hepatotoxicity, basically the liver tests have to be done, but these are usually done in patients who are more prone to develop liver problems because they are already having some liver issues, or they are on alcohol or something like that, where the liver function test may be having another risk factor. For peripheral neuritis, we give pyridoxine 10 milligrams per kg to the patient for whatever time patient is taking isoniazid. The dosage of isoniazid is 4 to 6 milligram per kg body weight. And other side effects which you can encounter, the important ones are lupus-like syndrome, or there are cutaneous adverse reactions. Rifampicin, the dose is 8 to 10 milligrams per kg. Nausea, vomiting, liver function tests, acute kidney problems, and then again the severe cutaneous adverse drug reactions, they can be present with rifampicin as well. Pyrazinamide 20 to 30 milligram per kg body weight, but the problem is usually the photosensitivity, arthralgia, dysuria can be there, but not severe cutaneous drug reactions are there. Ethambutol 15 to 25 milligrams per kg. Optic neuritis is the one which we are basically concerned about, and of course the adverse cutaneous reactions are there. So the pyrazinamide is the drug which does not have adverse cutaneous drug reactions. It's an is unique thing for that among all the 4 drugs. So important point for exam question. So that's about it. So this is the way we do the treatment. Now, a word about the latent tuberculosis treatment. In latent tuberculosis, basically patient is not having any signs and symptoms. It is just this seropositivity is there. So do we need all the latent tuberculosis patients? No. We need to do only treatment for the high-risk patients like HIV positive women. So you can use isoniazid for the prophylaxis for 6 months, or you can use isoniazid rifampicin combination, which can be used for 3 to 6 months. Now, what is drug-resistant tuberculosis? If patient is resistant to one of the drugs which you are using in the first 2 months, that is 4 drug regime, if any one of the drug patient is resistant to, then it is known as the drug-resistant tuberculosis. Here is an exception. If patient is resistant to rifampicin, we don't call it drug-resistant tuberculosis. We call it multi-drug-resistant tuberculosis, right? So isoniazid, rifampicin, and ethambutol, they are drug-resistant tuberculosis. But if I talk of rifampicin, then it is multi-drug-resistant tuberculosis. Multi-drug-resistant tuberculosis is also there if a patient is resistant to any 2 drugs, 2 or more drugs, right? So for drug-resistant tuberculosis, initial 2 months, you can use the remaining 3 drugs, whichever is the bacteria is susceptible to. And then you can give the 2 drug regime for next 4 to 7 months. This is how the drug-resistant tuberculosis is treated. MDR is not our domain, and that is treated by the specific group of specialized doctors. Then BCG vaccination. A very important thing before we finish this session, we cannot leave the session without talking about the BCG vaccination, because that is the only vaccine which is basically available for these patients. So BCG vaccination should be avoided during pregnancy because it's a live attenuated vaccine, and it should also not to be given to the infants who are on any type of immunosuppressive treatment in utero. Like if you are using biologicals for any disease, then you cannot use this vaccine for the infants for the first 6 months. Now, which infants will require the BCG vaccination? In UK, it is not a universal vaccination. It is to be given only to the infants who are at a high risk. So which infants are at a high risk? Whose parents or grandparents are from a place which have a prevalence of 1 in more of a cases of 1 in 40,000, more than 1 in 40,000, or the infant belongs to the place where the incidence or the prevalence of the tuberculosis is more than 1 in 40,000, or the baby is exposed to any person with the active tuberculosis, then you can give the vaccination to that baby. Breastfeeding, about breastfeeding is possible, where the patient can go ahead only if she has already taken 2 months of the ATT, which will make her seronegative, and now she will not transmit by coughing or by the secretions to the baby. Second thing, what are the other contraindications when baby should not be breastfeed? That is breast tuberculosis, or if the mother is having breast tuberculosis, or she is having multi-drug resistant tuberculosis, or if she is HIV positive. 3 conditions she will not feed. One is breast tuberculosis, multi-drug resistant tuberculosis, and third one is if she is HIV positive, right? All other things, baby can be breastfeed. Now, if a baby is born to HIV positive mother, can a baby receive BCG vaccination? Yes, baby can receive BCG vaccination, but you have to ensure that baby tests negative at 12 to 14 weeks and baby is completely formula fed, right? So in HIV positive mothers, babies can receive vaccination if they are negative, seronegative at 12 to 14 weeks, and baby is exclusively breastfed. So this was about a complete information of tuberculosis in pregnancy. Hope you enjoyed the video, and thank you so much for your patient listening. Do stay with us and do subscribe for more such videos and more such article summaries. Log into our website, that is on the bhavnakhera.kajabi.com, right? So be with us, stay with us for more knowledgeable videos. Thank you so much for the patient listening once again.